Okay, I'm Maura Quinlan. I'm a general OBGYN in Chicago and the Women's Health Medical Advisor for IDPH.
Nice to meet you. I'm Dr. Melanie Barnard. I'm a surgeon with SIU School of Medicine here in Springfield, Illinois, with a focus of treatment on breast cancer surgery.
As you're talking to someone who has had a new diagnosis of breast cancer, can you just go over the treatment options as she sits in front of you with this diagnosis?
Of course. So, first of all, getting a diagnosis of breast cancer is a terrifying thing. It's a very scary thing. And so, the first thing I tell patients when they come into my office is to take a nice deep breath because breast cancer, and especially early stage breast cancer, is extremely treatable. Now, treatment for breast cancer is actually a team sport. So, there's going to be multiple groups of doctors that are involved in a breast cancer patient's care. The first group of doctors is, well, me, surgeons. Our jobs are pretty straightforward. We cut out the cancer and we help stage the cancer. Most patients will have sampling of their lymph nodes as part of their surgery, and that's how we stage cancers. The second group of doctors are medical oncologists, and just like the name, their treatments are involved with medications. That can be some straightforward medications like the treatment hormone blocking therapy, which is a pill that you would take for 5 to 10 years. That can also involve treatments like chemotherapy. The third group of doctors is the radiation oncologists, and their treatment is radiation. Radiation is a very common treatment used in breast cancer patients and is typically done after the surgical procedure. So, yeah, a lot of different doctors, and the research really just shows that when all three of us work together, that's when patients get their best results.
Yeah, so I have a team. Obviously, the options of those treatment depends on the stage. How does stage factor into what the treatment would be?
So, the earlier the stage of a breast cancer, the easier it is to treat. So, this is where I think screening is such an important topic and why I'm such a huge advocate of everyone getting their mammograms, because mammograms can pick up cancers below the size of a centimeter. That's smaller than the tip of my finger, about the size of a pea. It needs to be 2 to 3 times, sometimes even larger than that, before you can feel it on an exam. And usually by then we're talking a more advanced cancer where lymph nodes might be involved. So first, when I talk about staging, I always have to say screening super important. Please get your mammograms. But as cancer gets more advanced, uh, it can get a little more complicated. It can involve different types of surgical treatments, such as more aggressive surgery for the lymph nodes. It can involve different medical treatments, including maybe a higher likelihood of needing chemotherapy or other medication types. And then it can also increase the intensity of your radiation treatments. So it's definitely treatable. And breast cancer we've gotten excellent at treating breast cancer at any stage. Even patients who present with stage 4, which means cancer that goes to any part of the body, can survive for years and years because of the advancements in breast cancer treatment. But obviously, best case scenario is to discover it early and small.
Yeah, makes total sense. This is a really broad question, but are there any sort of categories of side effects that you try to lay out early on for the treatment options?
So, and keep in mind, this is the surgeon talking about other people's jobs, but the side effects that you can have from surgery are pretty straightforward. They're the risks that you would get with any kind of surgery. So, small risk of bleeding, swelling, or bruising. There's a small risk of infection. We do surgery sterilely, and we give doses of antibiotics to help prevent infection. And there is risks of having difficulty with scarring. Now, the breast is different from any other part of the body because we tend to view the breast differently in terms of cosmetic outcomes, in terms of how that changes how we view ourselves and our body image. So that's why it's so integral into breast surgery of how we approach making incisions, how we treat the breast, because that cosmetic outcome actually is a part of treatment. Now, so that's the kind of side effects to expect from surgery. Now, with medications, really depends on what you're getting. In general, hormone blocking therapy, which is a very common treatment, the job of it is to help reduce the effects of hormones on the breast, and there's multiple ways you can do that. But typically, the symptoms are the same that you would get with menopause. So you can get hot flashes, you could see decreases in bone density. In general, I think most side effects, especially for medication, you think of them on a spectrum. I have patients who take hormone blocking therapy who ask me, hey, am I supposed to be feeling anything? Are they even working? And then I have patients who take it for a week and say, hey, I don't know if I can do this. This is pretty rough. And I usually tell people if it's recommended to give it a shot and see where you are, because a lot of people tolerate it extremely well. Chemotherapy, that's a whole nother talk. We could probably talk an hour about the effects of chemotherapy. In general, what I tell people is just the role of chemotherapy is to kill fast-growing cells. And since cancer are the fastest growing cells in your body, that's what the job of chemotherapy does. But the side effects of chemotherapy are related to fast-growing cells in your body. So the second fastest groups of growing cells in your body are going to be your hair, your bone marrow, and the lining of your intestine. So that's why we see the hair fall out. That's why we see sometimes nausea, vomiting, and diarrhea. And that's why we can see immunosuppression, meaning that you're more likely to get infections when you get chemotherapy, which is why we take special precautions. And then finally, radiation. Side effects of radiation, the most common is fatigue, actually. It's a daily treatment often. Monday through Friday, you go in for a 15-minute appointment. People can feel very tired after treatments. Second most common can be superficial skin burns, like sunburns. They'll give you ointments and special techniques to help prevent those side effects. It's something to watch for when you're undergoing treatment.
Well, it's nice to know that I think everyone's head goes directly to chemo.
Oh yeah,
And
chemo's, that's the
breast
first
cancer, I will
question.
lose my hair. And it's nice to know that not necessarily the case.
No, and interestingly enough, with chemotherapy, I think that's everyone's first question. And honestly, it's usually the last question answered is, do I need chemotherapy?
Right.
We used to give chemotherapy pretty broadly to breast cancer patients. But now we actually, most breast cancers go through molecular testing and genomic testing to see if you have what we call a high-risk cancer or a low-risk cancer. And now patients who have a high-risk cancer are given chemotherapy because it shows they benefit. But there's a lot of patients who have low-risk cancers who don't need chemotherapy because they're going to do well whether we give them chemotherapy or not. But usually we don't get that answer sometimes till even after surgery.
Well, this kind of leads to the next question. As you're talking to someone, who's newly diagnosed, what might someone expect in the next few years as treatments are evolving? What's coming down the pipe?
So there's a lot of advancements in treatment of breast cancer. On the medical side, we've seen huge strides in immunotherapy, which has been a really big game changer in difficult to treat breast cancers, especially triple negative breast cancers, which classically are extremely difficult to show improvement on. Immunotherapy, I've seen patients go through that and we re-image them and you can't see any cancer at all.
And triple negative, the hormone receptor
negative. Yeah. That means that it's not sensitive to female hormones, which most breast cancers are. And with radiation, they've really started better targeting techniques and different maneuvers to help reduce the field that you receive radiation, which reduces some of that side effects as well. On surgery, the advancements are really just finding out that people don't need as aggressive a surgery as we used to think. And people, with the advances in medical therapy, some people can get very small surgeries and do just as well as if they had had a very large, aggressive operation.
An easier recovery. And another argument for mammogram.
Exactly.
So if it's diagnosed very small, your incision can be proportionate.
You can end up with a very tiny surgery, an outpatient, and be back on your feet within a couple of days.
Yeah. Is there any advice you give to patients who are starting this journey for lifestyle? If they say, what can I do to maximize how I respond and diminish the side effects?
Yeah. So the first thing I tell people is your mental state of health is very much tied into how you do overall. And it's really easy for me to say to a breast cancer patient, don't be stressed out. But truly what I find is that breast cancer treatment, it's not a sprint. There are weeks in between tests or treatments, and often that whole process can last months. So really what I tell people is take it one day at a time. Find your people, family, friends, take them to appointments. It's good to have a second set of ears and someone to hold your hand, although I do that too. But have those support people in place. Take time to do the stuff that's important. Life doesn't stop because of breast cancer. So go out with your family, take vacations, do the fun things that you planned on doing. It doesn't stop just because you have that diagnosis. In terms of lifestyle changes, beyond just the, keeping that positive outlook, getting support, I would say obviously regular physical activity can be really good for the body, help reduce stress, and help improve heart and lung function, which can be very helpful when undergoing surgery or taking stronger medications, which can affect those functions. And then, of course, making sure you're eating plenty of protein and a nice balanced diet can help give your body the energy reserves to heal up from an operation, or also kind of build your strength as you're going through more aggressive treatments.
Oh, that makes sense. Any other than finding their people in their world, are there any other resources or support groups, anything that you point your patients to that women around the state could access?
There's actually quite a few. I mean, obviously check with your local cancer center, because we all have our groups that kind of get together. But even just nationally, there's a lot of social media groups where women with breast cancer talk about their experiences. They support each other. I've seen some of the most fun ideas from my patients from things they've gotten from the Facebook group, whether it was like, oh yeah, this supportive bra is the best for someone who's had breast surgery, or they'll get fun T-shirts and things like that. So it's really great to find those groups of people, and there's a lot of groups online, but always definitely check with your cancer doctors, because most places also have local groups that get together, and sometimes that in person can be really helpful too.
And someone in the community. Yeah, such great advice. Anything that we haven't covered that you think, in terms of treatment, someone who has a new diagnosis should wish they knew?
So what I tell people, I think the big thing I would say is, kind of like what I mentioned before, it is a month-long process, but it's just that, it's a bad year. It's not the end of the road, it's just a bump in the road. That know that for surgeries, there's a lot of different options, and it does not necessarily mean you have to lose your breasts. There are options that are just as good that are smaller. If you do choose to have mastectomies, there's a lot of options for reconstruction. You'll talk with Dr. Sommer, who is a fantastic plastic surgeon, and you can see some of these results are amazing. So even if you end up getting more aggressive surgery, there's a lot of options on that end. Even if you have to do chemotherapy, that's just, you get through those treatments and then you get back to normal. My favorite part of being a cancer surgeon, favorite part of breast cancer treatment, is my survivorship meetings. I love seeing my patients a year, 2 years, 5 years down the road, get to see, we trade pictures. I show them pictures of my kid. They show me pictures of their families, and just seeing how life moves on after breast cancer. So I think if I say anything about breast cancer treatment, is there's ups and downs, there's tough parts and easier parts, but it's just a season.
Thanks so much for being here. I'm Maura Quinlan. I'm a general OBGYN from Chicago and the Women's Health Medical Advisor for IDPH.
I'm Nicole Sommer. I'm a professor of plastic surgery at SIU School of Medicine, and a large part of my practice is breast reconstruction.
Perfect. Well, thanks so much for taking the time. I know this is a really relevant, often not the first thing that's discussed in people who get this diagnosis. Can you just kind of start from the beginning, a patient who's newly been diagnosed with breast cancer, what her options are for reconstruction?
Sure. So I usually want to find out from them what their general surgeon or their breast surgeon has told them as far as is the plan, what type of mastectomy they're going to have, because that will guide our discussion. Meaning that a patient could have a mastectomy on one side, they could have a mastectomy on both sides, they may be having just a partial mastectomy. So all of those things are going to factor into our discussion. I think as far as a mastectomy, what's most important to know is if they are okay with having anything done on the other breast at the same time, because that's going to also affect our discussion process. The way it works is insurance covers all breast reconstruction. And I think that's also very important for patients to know, because a lot of times they come in not even being sure if their reconstruction is being covered. And so then they're hesitant about even talking to me, because they don't want to talk to me about something that they might not even be able to get covered by their insurance. And usually I think the breast surgeons are very good about letting patients know that it is by law, has to be covered. The other thing that has to be covered by law is a symmetry procedure to the opposite side. So that's where that comes in, where if a patient is having a unilateral mastectomy, they can still have surgery done on the opposite breast to make that normal breast match the reconstructed breast. And by law, that's also covered with breast reconstruction. So when we've gotten all those questions answered and are trying to figure out what the options are, the main options for breast reconstruction after a mastectomy are either using an implant, so either a saline or a silicone implant, or using their own tissue from somewhere else on their body, such as their abdomen or their back or their thigh or their buttock. Those are all areas that we sometimes will use it from. And basically what that's doing is that's recreating the mound that the breast gave that the breast tissue gave to the breast. And so once that's been determined, the other thing that needs to be reconstructed at the end is the nipple and areola. Some patients don't have to have their nipple and areola removed at the time of the mastectomy. Sometimes they can keep it, which is called a nipple-sparing mastectomy. And whenever that's the case, it's great because it's much easier to keep. It's a much better result to have the normal nipple and areola there than it is to reconstruct it. We can reconstruct them, but I would never say that they're going to look as good as the real thing. So if we ever can leave a nipple and areola, we will sometimes do that. There is a bit of a risk with that because you are leaving a tiny bit of breast tissue behind in the nipple. So it will be determined by the general surgeon if that is a safe option for them or not.
Location of their cancer.
Exactly. The closer it is to the nipple, the less likely they're going to allow the patient to leave the nipple. And then there are some patients who say, I don't want to leave the nipple because I'm afraid that that little bit of tissue, I wouldn't have a good peace of mind knowing it's there. So then we just have that discussion. Well, that's great. That's fine. We can take off the nipple and we can do a reconstruction of the nipple later. So, and the nipple reconstruction is done in a couple different ways. It's done either by using the skin in that area to make a nipple, projecting nipple, and then tattooing or a skin graft to do the areola. Or a lot of people now are skipping the surgery altogether for the nipple and areola and just going to 3D tattooing, because the 3D tattoo does a really great job of making a nipple, not one that has any projection. It's flat, but it looks like it has projection. It's very impressive. It's 3D. It looks like there's a nipple there.
And that's all covered too.
Well, I mean, it would be covered if I did that part. When it comes to the tattooing, I used to do the tattooing, but I mean, I'm not a tattoo artist. And I can put some color on there. I've attempted 3D, can't say, that I'm going to master that, as that's not what I do all day, every day. So we actually have a tattoo artist that we work with that will do that for patients. And unfortunately, because they're a tattoo artist and not a medical person, it isn't covered under insurance, but they either do it for free or very inexpensively, so people are able to get it done.
And can you talk about the timing? Is this done at the time of surgery? Is it done delayed? Like, if someone chooses reconstruction, what's the timing in the
So they have both
journey?
options. The majority of people now, I would say, do an immediate breast reconstruction, and the factor in that is going to be if you live in an area where you have a breast surgeon who's going to do the mastectomy, and then you also have a plastic surgeon who can come in right after and do the reconstruction.
Same day, same
Yes.
OR, yeah.
When that's not going to be an option is if you live in a community where you have a breast surgeon to take the breast off for the mastectomy, but you don't have a plastic surgeon then available. No one say there isn't a plastic surgeon in your community who can do that. So we have patients come from surrounding communities for that reason. So they have a general surgeon, and that person's able and willing to do the mastectomy, but they don't have a reconstructive person there, and the patient wants to have it done at the same time, so they will come to Springfield to have it both.
I see.
Sometimes they'll have delayed because they lived in a community where they didn't have a reconstructive surgeon, a plastic surgeon, but they wanted to go ahead with their mastectomy, so then they'll come to me after the fact, after having the mastectomy. Sometimes they need to have it delayed for other reasons. Say maybe they just don't want to go through such a big surgery up front. They just want to deal with the cancer and then deal with the reconstruction later. Maybe they change their mind and they decide, I didn't want reconstruction at first, but now I do. There are unfortunately still some people who don't know about reconstruction, so they may not have had it done because they were never told it was actually even an option. That's getting less and less, thank goodness, but it's still something we kind of are trying to work on to make sure everybody at least knows their options before they undergo the treatment.
Are the risks different if it's delayed?
I would say the biggest issue is if someone has a very attractive, breast with no ptosis, nipple in a really nice position, not a lot of extra skin, if we can save that, the normal skin envelope, I think we're going to get the best result with whatever reconstruction we do. So in those cases, it is very beneficial, I think, for patients to have it immediately, so we're not taking any of that extra skin off. If you have a delayed reconstruction, what normally happens is a lot of that skin will be taken off. So then when we come back and do the reconstruction, we have to then either expand the skin, so we have to stretch it with something called an expander, which goes in the chest, then that's taken out and the implant's put in, but it makes the whole process longer because we have to expand it, or we have to bring tissue in by using their own tissue. Then they may have to fall back on that type of reconstruction, and implant may not be an option for them because their skin is no longer amenable to being stretched if it's in a delayed fashion.
Does it matter radiation,
Radiation
if
does
they have been
affect
radiated and then get delayed reconstruction, or if
Yes.
you do the immediate? Does it affect their treatment?
I mean, radiation affects in all scenarios. It affects the tissue, and it obviously is necessary for treating the cancer. So I would never recommend not doing the radiation, but I do warn patients that it does affect the end result to some degree, and it can affect some people not at all, and other people quite a lot. And we can't always predict on who that's going to be. So in a situation where someone wants to have implant reconstruction, it's very helpful for them to have that immediately, or at least before they have radiation, because once tissue has been radiated, it makes it much more difficult to use an implant reconstruction because the skin just doesn't stretch. It's just not normal. So especially in a situation where, say, someone had a mastectomy, so none of the skin was left, they just had a flat chest, and then they had radiation, that person is really not going to be able to have implant reconstruction anymore. It affects their options.
It won't be able to, it won't stretch.
It won't stretch. So then they're going to have a situation where they use their own tissue. They're going to have a flap surgery where we take tissue from the belly or the back or somewhere else to recreate the breast mound, because an implant's no longer an option for them. So in that respect, I always want to encourage people that if they're at all interested in implant reconstruction, they definitely really need to see a plastic surgeon like myself before they have the mastectomy, so we can figure out the timing to make sure that we've kept that door open for them.
If they choose immediate, it doesn't affect the effectiveness of their radiation. It doesn't compromise their prognosis or their treatment if they do it at the time versus delayed.
Correct. The only thing we would worry about is if it would delay the radiation significantly. As long as it doesn't delay like say if they had a wound healing problem or they had a problem with their reconstruction, our worry would be that if it delayed the radiation, it could delay their treatment. But obviously we make sure that that is not the case, meaning that if someone was, this is an incredibly rare scenario, but say if somebody was having issues with their breast reconstruction, we would make sure that that was all figured out, whether that be aborting breast reconstruction or doing a different type of breast reconstruction or getting them healed so that we don't delay the radiation. Because as long as nothing's delayed, it doesn't affect their prognosis.
The radiation works
with
implant or not.
Right, right. The only thing that the radiation does do to a reconstructed breast is that it can change it. Meaning, so we can have a great result from reconstruction and then it gets radiated and then it cannot be as great of a reconstruction after it's been radiated, because the radiation can really affect the implant. It can cause something called capsular contracture, which is a hardening of the scar tissue that on the inside that forms around the implant, so it can make a breast firm. It can affect the way the breast, that mound kind of sits on the chest, so it can make it tighter. So it can change it. And so that's something I explain to patients before they even get reconstruction, is that radiation can affect it long term.
Yeah, and are those permanent?
Usually once you have radiation changes, they are permanent to some degree. It kind of depends on the extent. One thing that we are doing more now that does help a little bit with that is fat grafting. That's something that we've been doing where we do it to help contour the breast if there are areas where it's thin or bumpy from the mastectomy. Or we do it if patient has radiation damage or change. Sometimes fat grafting that tissue can bring some stem cell regeneration into the area, which can help a lot with that.
The insurance coverage for reconstruction covers all of this.
Yes.
However long you need
Yes.
to do whatever number of procedures, it's all covered if it's
Yes.
part of breast cancer.
Yes.
How do you manage expectations for patients? Like, how do you counsel them to know all this range of possibilities?
Well, it's difficult because usually they're coming to see you after they've just been told they have breast cancer. So how much of it they're hearing is very difficult to tell for sure. It is helpful to have someone with them that maybe is taking notes for them. I encourage them to come back and see me a second time to discuss it if they feel like they need to. It's a lot of information. So I just try to give it to them as simply as I can. And I try to get an idea if I can feel like they're understanding what I'm saying. And we just talk about all of the different options, and then at the end, we come to a conclusion. Hopefully, sometimes when I've seen them, the breast surgeons haven't decided for sure what they're doing. Like maybe they don't know if they're doing a unilateral versus a bilateral, one-sided or both-sided, or they don't, or maybe they're doing a partial mastectomy and not a full mastectomy, or they don't know for sure. That is sometimes makes that conversation even more difficult. Right. So then we have to have them come back, usually once that decision's been made, to discuss it. But it's hard. I would say that is the most challenging thing, because you just don't have the time to really absorb all of that information.
And there's so many options
Yes.
that they need to choose, as opposed to breast cancer treatment. Here's what we recommend. But for you, it's, and I've had so many patients over the years who say, I feel like this is vanity. I have cancer. I just want to get through this. I shouldn't care how I look anymore. But I think it's great that that's part of the recovery, and that it should be their choice.
Right. And I think the other thing that's interesting is that there are some women who don't want reconstruction, and they see the flip side. Their primary doc or their breast surgeon is demanding that they go see a plastic surgeon, and they're like, I don't really want to see a plastic surgeon. I don't want, so I'm only here because my doctor told me I had to come. And I'm like, that's okay. You can hear your options, and then you're even more informed when you decide you don't want breast reconstruction. You just want to have a flat closure. That's fine. Right. But at least hear them, and then you've made a completely informed decision on that.
And know that they're covered, and it won't affect your prognosis should you elect to choose them. Is there anything, when you have patients who are about to undergo reconstruction, that they could do lifestyle, if they say, what can I do to help improve my chances of a good cosmetic outcome, recovery, healing?
Stop smoking, stop any nicotine products if they're taking them. Eat healthy. Just, don't go on a diet right after you've found out you've had breast cancer. Eat healthy. Eat lots of protein, eat lots of vegetables, cut out all the extra sugar, just eat healthy. As far as exercise, there have been some studies that have shown that women who exercise through this process do better. So it's always, I encourage women to do that. Obviously, it's helpful if you're already doing it, just to continue. It's a little bit hard to find out you've had breast cancer and now try to be exercising and being, but just trying to be active, I think, is helpful. Having a support system. I think, I don't think there's any rocket science in it. I don't think you have to start taking, vitamins and all that. You just really have to try to be living a healthy lifestyle as much as possible.
Is there anything that you wish your patients knew before they come to see you?
The thing is, it's not like I can say, well, kind of come in with some ideas of what you might like, but they don't have a basis to even make any of those decisions, right? So, obviously, if they could know what the breast surgeon has decided, that's helpful. But like I said, a lot of the time they either do know, or that decision hasn't been made yet. So they don't know because it hasn't even been made for them yet. Or they come in and they still have to have an MRI to look at the other breast, or they still need their genetic testing to find out if they're at high risk for recurrence. They still have a lot of information still that they don't have the answers for sometimes when I see them. Because we're trying to get the whole process going quickly. So a lot of times I will see them in consult before all of that is figured out, because we don't want that to slow down the process. If they kind of read a little bit online about breast reconstruction, sure, that would be great, but I'm just not sure I would ever expect someone to have put that kind of effort in when they have no idea what I'm going to be talking to them about.
Are there any websites, anything that you recommend?
There's definitely lots of information. It's probably too much information, honestly, in that people probably get overwhelmed by it. I think it's helpful to probably wait, have your first consultation, and then maybe start looking at some of the things we talk about, and then come back in, like I said, for a second, discussion. Sometimes we'll also have patients talk to other patients who've had different procedures, especially if they're really struggling with which way they want to go. We may have them talk to a couple different people who've gone the different ways, so that they can kind of see what their experience has been.
And to know that it's covered is huge. To not think about an additional expense for symmetry.
Right.
Great. Thank you.